I mean, could you do a mix? A lot of times, if you see this color, darker, especially if it doesn't pump up, I mean, if your patient's pressure is 140 over 85 and the blood is barely coming through, maybe it's venous, maybe it's mixed, but especially if it's dark. So document that. Question: how could you know when the blood gas comes back whether that was venous or mixed or arterial? What's one way?
PaO2 would be really low.
PaO2 would be low. What else can you do? What can you note to compare?
The CO2 bicarb will be different numbers, like different ranges than
Okay.
the other.
What else?
Well, it'll be all the.
How
it'll
could
be
we correlate it with what else? Do not tell the rest of the class. This will be the question of the day.
So you're trying to just decide if it's venous or arterial?
Once the results arrive, we can say, yeah, this was definitely venous because
Well, 'cause when
the
ADA
pH.
normally
I
the
was like,
PaO2
yeah, I was
would
like,
be super-
maybe the
That's what
pH.
Tracy
Wow, I
told
thought
us.
I was
that.
like, yeah, or
could be. I'm just looking at one extra thing that you should probably write down. Again, not all places require, but I always did. I always wrote down what my fill in the blank was at the time I drew the blood gas.
The color.
The pH.
The
I won't know the pH until
Oh,
we
yeah,
run
yeah,
it, right?
So like color of
Honestly,
it, the
We
consistency.
had a bright red one that was like, he said it was oxygenated, really oxygenated, so.
So if it was really dark.
Okay, so that, but again, I document something prior to running this that might give me a clue as to what I drew. Is it mixed or is it venous? Or does it correlate?
I don't know what
I was doing in my head. I was
Like-
like, I don't know.
I'm trying to think what else.
Would it have
Just
something to
besides
do with the
color and
bleeding factor?
consistency.
Nope.
Oxygen
What? Oxygen what?
level is your the one like oxygen.
Oh.
SpO2.
Yeah.
So if your SpO2, nice little waveform, you guys have hopefully at this point seen dampened waveforms, like, I'm not sure I can trust it, but if it's picking up real well, and it's 98%, and you get your gas, and the SaO2 is 85, we expected SaO2 to be a little bit lower, right? Because SpO2 is a combination of O2, the hemoglobin being bound with hemoglobin and met and carboxy, right? So SpO2 is going to be a little higher, but only by a little bit, right? Unless you have a huge carboxy or met hemoglobin problem. Does that make sense? Hopefully this is coming back from last year. So that's that in combination with, yeah, it didn't really pump up very well, and yeah, it was pretty dark, kind of gives you the confirmation that, yeah, this is probably either venous or mixed.
So if you drew that and you had a hunch, would you do another ABG and do another research?
It depends on the place.
72
Some
or-
places will say I got what I needed because it's approximate, especially if you're looking for the CO2, it's not going to change a ton. pH is not going to change a ton. But if you're looking for a specific PaO2 and SaO2, then sometimes you may withdraw. You may, redraw it, I should say. I wanted to make sure that you guys saw this. And FYI, these are the kids that you guys should be practicing with. Ooh, I like this one because this one, instead of the
Oh, yeah.
safety being,
Oh, is that the one where you like crack it? Kind of?
yeah, you
just
That's what
push it
the
on.
I think it's safer because I have seen, especially if you get a little overzealous, poking through some of the safety, what are they called?
Cushions.
Safety cap. But this one kind of gets in the way as you're trying to draw. So you guys will play with these in practice. But please use these as the full. This is what we're going to use for the checkoff. But they're, instead of having you guys buy these, we supply them, but they're about $1 each one of these. So obviously try, if you need a needle, I want to make sure you guys are not reusing the needles, even though you're not really sticking people, so it's not a huge concern. But we also have as many as you can use these if you just need the needle portion. Okay? So as you stick, what you should see, I wanna make sure that you guys can, as you stick it, you should see the flash, and obviously you're gonna pretend that you don't see me aspirating, but this is what you're looking for. So there's this flash, do you see that? So you know you're in, and then you just stay there, and what it should do is just keep bumping up, a little faster probably. So much for that. But I wanted to make sure that you guys saw the flash piece. Do not
When you
ever
see that
recap.
flash, you're gonna hold your breath. I guarantee you, you hold your breath and you don't move. Like, and then it fills up because you just hit the artery and it's filling. And in your head, like the very first time when you do it, it happens to everybody, you hold your breath and you don't move. You're like,
I'm gonna have to notice that.
yeah. Everybody I've talked to is like,
So if you have it pulled up to like at 1 approximately and it fills all the way up, then you stop. Okay, so this is what I was trying to describe. So now notice, what do we have at the top?
Air.
Air. And make sure this is nice and snug. And by the way, you should be wearing, what else? Goggles.
shield of some
Or a
sort.
shield, yeah. Flip it, so if that, we know that we have a big bubble right there. But if we have any little bubbles, flip it. And then notice what will happen. So you had the bubble went up in there, and then it will stop, it won't hold anymore. So now as you do a visual inspection, wear your glasses if you're not able to see like me, then mix it. Okay, the syringe itself comes pre-heparinized because we want to make sure that we prevent clotting. So we really want to mix everything up when you learn. What else?
what do you think this needle? You got 2 of them in a package.
Got one bigger, one smaller.
For what?
Bigger and smaller ribs.
Brachial versus.
Oh,
Brachial and radial. So in your pack, you'll have a longer needle and a shorter needle, depending on where you go. On some people, you could use the radial, but this is generally what you'll use for brachial, which is up here.
Let me show. So if you do, or if you have a patient that is large and you have to go through a lot of tissue, perhaps you should not, no matter what size, use this one for the radial. Because at that point, you'll probably poke straight through. But if you do have to poke, to do a brachial pulse, everybody feel your brachial pulse. It should be on the inside, so in this case, in the pinky side. If you overextend, you might not feel it. If you underextend, you might not feel it. So be sure as you're practicing. No, it's there.
This is a good practice at home. You'll go like this all the time. So your radial, go down your thumb, and it's on the inside here. Your brachial, this is gonna follow all the way down. Like Sonia said, it's towards the inside, your pinky side. You can start, I call it the armpit of the elbow here. Start here and start feeling. Sometimes you'll feel it way up here, but just slowly start going until you feel it. And you'll feel it. It's a bigger artery. You'll feel it just bouncing. But if you're just sitting there wasting time, feel your own pulse. That way you kind of know where to go on somebody instead of starting here.
If you do have to go brachial, when you do that, I'm not gonna stick you, but the angle, so depending on where you feel it, I feel a really good one right there. The angle is not 45, you kind of go at this angle.
I feel like that's
Again, we will not be checking off on brachial. Some places, that's what they go straight to the brachial, but what do you see as a potential problem there?
Bending their elbow.
I feel like there's a lot of bleeding now.
No, not really. It's actually a bigger artery, and some patients will say it doesn't hurt as much
Yeah.
because
have-
there's not a lot of nerves
Do you
around.
have the same issue if you were to blow it out or something? You can't go lower.
So if we get rid of the brachial, we have ulnars out and radials out.
Yeah.
So very, very important on this one to really pay attention to, is your patient on anticoagulants? Lots of patients are on anticoagulants. How long do you have to hold it? Because if you don't, at that point, I did see one patient, Michelle used to, because she taught the AVG classes at Kettering, of one patient where they did a brachial, didn't hold pressure long enough, just kind of barely wrapped it, walked on. It kept on bleeding. Long story short, this was all black and blue. She had all sorts of issues. So we can cause some significant problems if we're not careful.
And a lot of the times, Patch, where do you put a lot of your IVs at?
and Q.
So a lot of the times your IVs are right there, and it's really hard to go there. So radial is usually the first choice, and then try brachial. So
And then if 1, 2, and then that's when you call the doctor, whoever, to do the
yeah,
femoral,
depending
if
on
it
where
gets to
you
that
are,
point.
yeah, the femoral. That's the only other place you've got.
Yeah.
You got 3 places. After that,
We have the pedal, that's the foot, but I have not seen anybody.
Do you ever do any like jugular or anything like that?
no. Usually, if you can't get it here and here, I'm on the phone with the doctor, telling them it's time to put an art
Speaking
line.
of,
That'd be
speaking
fun.
of that being a big bleed issue.
Funny,
Um,
Olivia were talking about that. She was like, "Yeah, just stick it in." Exactly.
Another thing to
Shouldn't be able to
remember
miss at that point.
is if you can't feel a pulse, it doesn't mean that it's not there. You can always get a Doppler. Because
they
then
had
you
to
may
do that,
see
yeah.
individuals. So ask your clinical instructors if you can get a Doppler, because then you can actually see the artery pulsating, and then when you enter the needle, you can actually see.
I've seen those, like when I'm working in the ER, just registered